Hello, everybody. I can still see people logging on. The number of participants is still going up, but I think it's about time to start. Welcome to this ERN-RITA webinar. This is the first one, which is on behalf of SCID, so dealing with immunodeficiencies. And I am very happy to introduce our speaker today, Dr. Fabian Hauck, also from Munich, Germany, where he is currently the head of the Immunology department. And he has been involved in the last 8 years or so in the introduction of a nationwide newborn screening program for SCID in Germany. And today he will educate us about the background of newborn screening for SCID and the first preliminary experience that were gained in Germany and what we can learn from that. And I am very much looking forward to his presentation because I believe this is a subject that will be important for many people throughout Europe. With this, without further ado, I would like Fabian to start. Just let me say one thing. If you have any questions, we have a dedicated Q&A session right after this talk. Please feel free to post your questions within the webinar system where it says question. We will be able to read these questions. I will then ask them to Fabian after his talk. Thank you very much, Fabian.
Okay, so thank you. I have to share my screen. Okay, so hello, colleagues and friends. Thank you, Michael, for the opportunity to present data and background on nationwide German newborn screening for SCID. And as we are about 100 participants, I think it is worthwhile to start from the beginning. And the beginning is always the patient. So I will start giving you a case report on a PNP deficient SCID case as it presents clinically, because this is what you all have seen, what you all see, and what you all hopefully will not see anymore in the future. So the patient is the first male child of consanguineous parents and initially was healthy, but at 12 months of age, the child developed psychomotor developmental delay, and soon thereafter, at 14 months of age, received his first live vaccination with MMR-V vaccination and developed severe hemorrhagic varicella. So VCV typing was done and the VCV vaccine strain was isolated. Given the combination of an opportunistic infection, because the live attenuated vaccine is an opportunist, leading to a severe clinical phenotype, there was, of course, strong suspicion of an inborn error of immunity, which led to immune phenotyping, and the child was found to have a T-, B-, NK- lymphopenia. Following the guidelines and our experience, we therefore had the combination of developmental delay, T-, B-, NK-, SCID, probably. And this is why we went straight ahead for ADA and PNP enzyme activity testing, and the child was found to have reduced PNP enzyme activity. The diagnosis of PNP SCID was further confirmed by Sanger sequencing that identified the homozygous splice site variant. So we had a clinical presentation of a PNP SCID. This is a clinical picture of the child showing a severe opportunistic VCV vaccination strain infection, and it got worse thereafter. Of course, you all know that the only thing to do is to go for immune system replacement, and in this case, this means stem cell transplantation. So the child received myeloablative conditioning. There was no matched donor available, so we went for haploidentical transplantation, taking advantage of TCR alpha beta depleted peripheral blood stem cells from the father. and the transplantation was quite smoothly without any major complications. The child was cured from VCV infection. However, 3 months after successful transplantation, neurological damage progressed, and we found pathological EEG with thalamic lesions and a progressive brain atrophy in the image. So brain biopsy was done, and vaccine strain muscles, inclusion body encephalitis had to be diagnosed. And in this point of time, of course, this was an enforced prognosis and the child passed away. What is SCID? And it's quite interesting that actually only with the start of newborn screening in the US, there really was a need to go for SCID definitions. And this is why at present the mostly currently available definitions are based on recommendations from the US, as you will see in the next picture. But from a more biological point of view, SCID can be defined as a developmental and or functional disorder of TB and or NK cells. Historically, you know that SCID has been diagnosed by immune phenotyping, and as a function of the cellular populations that were absent or present, the terminology of T minus, B minus, NK plus, for example, or T minus, B plus, NK plus SCID was coined. However, it is important to understand that SCID principally is a T-cell disorder, and that the majority of these patients is T minus. However, there are T positive SCIDs, and this can be the consequence of a peripheral expansion of oligoclonal T cells or pure functional disorders, which will not interfere with development, but only severely reduce T cell function. Going back to the data, the state of California, which has pioneered SCID screening, published an incidence of 1 to 58,000 cases. However, in highly consanguineous populations, there are estimations saying that the incidence might be higher, with 1 in 5,000, for example, in Saudi Arabia. SCID manifests in early infancy with recurrent opportunistic infections, bacterial, viral, fungal, and parasitic infections, and this leads to a failure to thrive, maybe because of chronic diarrhea or a catabolism. And in the particular setting of Omenn syndrome, SCID, of course, can present with erythroedema, alopecia, and hepatosplenomegaly. So the clinical presentation being shown in more detail, of course, is characterized by the infections. And you can see that there's viral infections, bacterial infections, fungal, parasitic infections, but as well live vaccine complications. Having a look at all of these infections, it becomes clear that a lot of them are common in the children. So in SCID, it is more the frequency, the chronicity, the non-responsiveness to treatment, which will make the difference, with the exception of some particular situations. So of course, the pneumocystis jirovecii pneumonia or the cholangitis with Cryptosporidium parvum is a hallmark of SCID, because this is an opportunistic infection. Live vaccines as well are opportunistic, and we see rotavirus complications. Some of you might see oral poliovirus complications. MMRV is quite common, and BCG complications, depending on the national vaccine schedules, can be an initial presentation of SCID. Of course, we have severe immune dysregulation displayed by the Omenn syndrome, and there's a particular presentation, which is the graft versus host disease, that can be due to maternal engraftment, because maternal T cells can pass the placenta and seed in the severe combined immunodeficient child, or T cells can be transfused by red blood cells that have not been irradiated or depleted otherwise. So to give you an impression, this is Omenn syndrome, which is the most severe immune dysregulatory disease that we are aware of. You can see maternal engraftment leading to graft versus host disease. As you already have seen, opportunistic infections can present in SCID, And overall, this is a very severe disease which leads to failure to thrive. And this child could as well be a neuroblastoma stadium 4. So it's really a devastating disorder. In 2010, however, Brown et al. From the Great Ormond Street Hospital had a very fundamental publication that shaped the field thereafter, because when they went into their medical records, they retrospectively identified 48 cases of SCID. These patients that all had been diagnosed late, which is clinically because they had symptoms, had a very poor outcome. So you can see that 35% of them even passed away before treatment, and that the ones that went into stem cell transplantation in addition had a high mortality of 39%, leading to very poor overall survival of 40%. However, when they analyzed the data from the siblings, which is children that had a new genetic risk because one of the siblings already had presented SCID clinically, these children were diagnosed early without complications, and what they found is that these children almost entirely progressed to stem cell or gene therapy, and that there was only 8.5% of the death associated to treatment or thereafter, and that the overall survival could be improved from 40% to 90%, which is a major achievement only because it was clear that the child had SCID before the clinical symptoms were present. So the question that arose at this time was, how can we identify asymptomatic newborns and hopefully reach 100% survival? To go for this, of course, diagnostic criteria had to be established. And this is what Shearer et al. Proposes, and this is what commonly is used in the community, I suppose. So, of course, a SCID-causing genetic condition would allow for the diagnosis in most cases. The clinical findings, of course, they do, but this is exactly what we do not want to see anymore. And some of these patients can be asymptomatic quite long, because when there's no exposure to pathogens, SCID might manifest later. There is a set of immunological findings in a newborn. So SCID can be diagnosed when CD3 positive T cells are lower than 300 per microliter, when the PHA-induced T cell proliferation is less than 10% of the control, and of course in the case of maternal CD3 positive T cell engraftment. For the Ormond syndrome, numbers slightly change, and the T cell count can be bigger than 300 per microliter. The proliferation of the T cells can be somehow less affected, and importantly, to diagnose Ormond syndrome, T cell oligoclonality is necessary, or loss of naivety, which is the presence of CD3 positive, CD45 R0 positive T cells bigger than 80% in the newborn. Maternal engraftment is not a feature of Ormond syndrome, because in Ormond syndrome it's autologous cells. And of course, the full clinical picture would be skin rash, alopecia, hepatosplenomegaly, lymphadenopathy, eosinophilia, and increased IgE. You are all aware of the IUIS classification, which gives you the genetic background for SCID. And just as a short reminder, there's a lot of monogenetic disorders known at present, and I think in between 15 to 10% of SCID patients at present do not have a genetic diagnosis. But what you of course can appreciate in this slide is that a particular genetic lesion, such as ADA SCID, will result in a particular immune phenotype, such T-, B-, and K-, or for example, T-, B+, and K+ in the case of IL-7 receptor deficiency. There is the phenotypic SCID classification as well, which has recently been updated and published by Busfier et al., which is helpful to go through your immune phenotype in daily life when you want to be sure that you don't forget anything. But I have to mention that these immune phenotypes can be misleading, because still the deficient immune system in the SCID baby can be very variable and very dynamic. So in case of infections, the immune phenotype might be misleading. But the combination of these both clinical and phenotypic, genetic and phenotypic classifications, at least in my hands, are very helpful. So let's focus on the biology of T-cell development, because this is crucial to understand SCID and how we screen for SCID. You all know that the hematopoietic stem cell in the bone marrow will send out lymphoid progenitors, which will seed the thymus. So you can see the thymus here. And once this lymphoid cell has entered the thymus, it will follow a developmental trajectory having different stages that can be defined by immune phenotyping. And finally, there will be single positive cells that will leave the thymus as naive CD4 helper and naive CD8 positive effector T cells. You can appreciate that the particular genetic lesions that we know to cause SCID will interfere with developmental steps that have to be undertaken by the thymocytes. For example, the RAC1, RAC2, and so on, genetic lesions will interfere with VDJ recombination and will lead to SCID. And you should focus on these signs down there, because you can see that in parallel to the cellular development, there's molecular changes going on in the thymocytes, which will actually lead to the development of individual, which is clonal T-cell receptors. And this process, as you all know, is called VDJ recombination. And finally, as a byproduct of a productive rearrangement and an operational T-cell receptor, will lead to the generation of the so-called TRACs, which is the T-cell receptor excision circle. So you can see here that the germline locus, for example, for the TCR beta chain, initially will rearrange somatically gene segments, starting with a D to J rearrangement, and then next a V to DJ rearrangement, and that this will be transcribed into precursor mRNA. And via splicing, the mature mRNA will be generated, will leave the nucleus, and will be translated to give birth to T-cell receptor beta chain that then, in combination with an alpha chain, will give you a functional T-cell receptor. Importantly, the gene segments that are not included in this productive rearrangement, they will be excised and they will be left in the cells as a so-called episomal DNA structure. So you can see here that there's the VD signal joint, which is a common feature of these tracks. And these tracks, they are very robust because they are circular episomal DNA molecules. It is important to understand that this signaling joint, as depicted here, is invariant, because the delta RAC segment will be joined with the PJ alpha segment, and this gives you a unique signal joint independent of the additional gene segments that have been cut out. And this finally enables you to go for an RT-Q PCR with a unique set of primers, which will detect all the tracks around in the cell, independently of the particular T-cell receptor repertoire. Just briefly, I would like to introduce the concept of loss of T-cell naivety, which is important to diagnose SCID and which is important to understand while drugs work as well in a setting of normal lymphocyte counts. So you can see here secondary lymphoid organ, which has a nice T-cell population. In the case of an acute insult, for example, chemotherapy, but as well in the case of SCID, this compartment is depleted of T cells, and there's a relative misrelation in between T cells and the stromal factors such as IL-7 or IL-15 or self-protein MHC stimulation, which in the setting of SCID can lead to a homeostatic expansion of oligoclonal cells that will repopulate the secondary lymphoid organ, but still will be oligoclonal. And it is important to understand that these cells, which have not experienced antigenes, nevertheless, because they have expanded and they have proliferated, will change their phenotype and will acquire a memory-like phenotype, which is CD3 positive, TCR alpha beta positive, CD45R0 positive, or RA positive in the case of EMRA cells. So this is an important concept. And another nice picture that has been done by Carsten Speckmann is this. You remember the stem cell will enter the thymus, will go for development, and then leave the thymus as a single positive CD4, CD8 cell with one track. In the case of activation and proliferation, the cells can expand, reach normal numbers in the case of severe lymphodepletion, but the tracks will not be amplified, so they really are a true biomarker for naive cells. And early in the 2010s, there have been studies, for example, the one cited here by Borta et al., that already have shown that quantification by RT-qPCR of tracks for T cells or tracks for B cells really is a tool which allows you to detect lymphopenia, or better, lymphopenia of naive cells. So you can see that the normal healthy population clusters here, and that the patients that have severe naive T and B cell lymphopenia, such as the RAG1s, are down there, while the ones that have B cells but are depleted of naive T cells, such as IL-2-Hg or IL-7RA, will cluster here, and that it is possible in addition to only screen for pure B cell deficiencies, such as BDK deficiency. So just a brief intermediate summary. Newborn screening started 2008 in Wisconsin in the USA, and now is recommended for all federal states in the USA. In Germany, we started some years later, and I will show you why, last year in August 2019. It is possible to do newborn screening with a regular Guthrie card, as you can see in the picture, which is already available in most countries. One has to screen for T-cell receptor excision circles to look for naive T cells, or kappa-deleting recombination excision circles to look for naive B cells. And these biomarkers result from VDJ recombination. They are non-coding episomes. There is non-coding invariant structures, signaling joints that can be screened for by PCR. And it is important to remember that the tracks and the cracks do not replicate during T and B cell proliferation. Of course, RT-qPCR has been mentioned, and as a summary, these structures are biomarkers for naive T and B cells. As it is a screening, a positive screening result has to be validated, and the first step would be flow cytometry. I will give more details on that. And of course, the SCID diagnosis should be confirmed by molecular genetics to guide you for family counseling, but as well to identify the patients which have a radio sensitivity and might need special attention when going for cure. And now would like to present you the screening algorithm we have established in Germany. I realized quite late that it is in German, and I didn't have the time to adapt it to English, but I will walk you through these algorithms. So there will be a first Guthrie card, which will be the first screening card. In the case of the tracks being bigger than the cutoff defined by the screening lab, and this depends on the screening lab and the technique employed, there are different possibilities to do the track screening. The screening might just be negative, which is the case for the majority of the newborns. However, when the first screening card will give you a track smaller than a cutoff, there are two possibilities. There is the possibility of the tracks missing totally, so zero, no tracks at all. And in the case of this newborn being older than 32 weeks of gestational age, this would, at least in our algorithm, trigger the urgent positive pathway, which would directly lead to a level 2 diagnostic in the Center for Combined Immunodeficiencies. So this is the two extremes: no screening negative or screening urgent positive with no tracks. However, there's a lot of in between, and in the case of absent tracks, but the child being a premature baby smaller than 32 gestational weeks, we would go for a second card and do retesting, and this again could lead to a negative screening or could confirm the tracks being smaller than the cutoff, or again no tracks at all, which would go for the urgent positives as well. Alternatively, the track cutoff could be, the tracks could be smaller than the cutoff, but the child could be bigger than 32 weeks of gestational age. This would as well trigger a second card, and then again there would be the possibilities urgent positive or tracks repeatedly smaller than the cutoff, which would lead to a normal positive screening and would trigger the level 1 diagnostics, which could be done in the kid hospital or the kid center. I will come to that next. So you see there are possible, there are different ways to finally have a positive screening. Might it be positive or urgent positive? And this will trigger different intensities of confirmatory diagnostics. So we have established a network which starts with the screening lab, which will have the first card and which will report the result back to the sender. The sender will inform the parents, and in case of a positive screening, they will go to their pediatrician, and there might be a second card and the second result. If this is positive as well, the pediatrician would refer the child to a kid hospital for level 1 diagnosis. But remember that the level 1 diagnosis can be followed by level 2 diagnostics, or more importantly, in the case of the urgent positive first or second testing, the child would be referred directly to the center. The screening lab as well will contact the center in case of an urgent positive result to assure that the center is aware of a child being at risk. And in the case of this pathway not working correctly, the center could reach out for the patient as well. Of course, the kid hospital and the kid center will give feedback to the screening lab to improve the cutoffs and to improve diagnostic quality and to go for troubleshooting and communication. And the screening lab as such will communicate the data to our National Society for Newborn Screening. In addition, we have established a SCID screening hotline, which is principally run by the people from the kid center. So it is possible for the pediatrician and the kid hospital people and the screening labs to get information in the case of arbitrary results or in the case of an unknown situation. This screening hotline is not expected to answer the questions of parents. So this is just a backup for the professionals, but we find it is a very helpful tool. So to establish the landscape of kid hospitals and kid centers, the ARPI, which is the German-speaking working group for primary immunodeficiencies, has developed a questionnaire, has set the requirements for the hospitals, and then run a survey. And this ended up in approximately 20 hospitals in Germany, which have now the label of kid hospital. And this is because in the first step, we want to have the children not to travel that much, because still at this level, there might some false positive results. In addition to the kid hospitals, we have the kid centers, which are responsible for the urgent positives or the level 2 diagnostics. And you can see, for example, that the Berlin Charité Hospital is one of the centers, Hamburg is one, Hannover is one, Düsseldorf is one, Frankfurt, Würzburg, Freiburg. We have Tübingen, Ulm, and Munich, of course. is one of the KIT centers. What is level 1 diagnostics like? Level 1 diagnostics is taking place at the KIT clinic, and as always starts with a medical history and a clinical examination. Complete blood count is necessary to have absolute counts for the immune phenotyping, and of course, at this level, you are at least interested in IgM and IgG. The immune phenotype is very basic, but includes absolute numbers for CD3 positive T cells, 3 and 4 positive helper cells, 3, 8 positive cytotoxic T cells, and very important, naive and memory like helper T cells as defined by CD3 positive, 4 positive, CD45 are seropositive, because this can really make the difference in the case of maternal engraftment, Omen syndrome, or otherwise peripherally expanded cells. And in our experience, this is still a problem to get proper staining for these populations. Of course, you are interested in B cells, CD19 positive, and NK cells as well, 1656 positive. When one of the results is suspicious and there's no prematurity as defined as a gestational age of smaller 32 weeks, we would recommend to interrupt breastfeeding in CMV positive mothers, and we would start level 2 diagnostics at a KIT center. Level 2 diagnostics is more detailed. Of course, there is a more broad immune phenotyping. Again, T cells, helper T cells, cytotoxic T cells, naive in memory like T cells, but in addition with a secondary marker to really get the truly peripherally expanded cells. In addition, you can go for recent thymic emigrants. Alpha beta and gamma delta T cells have to be looked for. TCR beta repertoire analysis is necessary in the case of Omen syndrome or maternal engraftment. B cells are necessary, NK cells are necessary, but now functional testing is important as well. So T cell proliferation should be assessed with PHA and anti-CD3, anti-CD28. Enzyme activity can be done, or the metabolites can be measured for ADA and PNP. And importantly, cellular radiosensitivity has to be addressed. But of course, in a lymphopenic child, this might be difficult, but this should be addressed on a cellular level or genetically. Maternal engraftment has to be excluded. And when the results are confirmatory of SCID, an intensive individual immunological workup, including molecular genetics, has to be started, because this already setting the stage for the curative approach. There are different scenarios one can imagine. So in the case of a SCID, a leaky SCID, or an Omen syndrome, of course, the child will go for allogeneic stem cell transplantation or autologous gene therapy at a KIT center. However, there's a lot of additional findings, for example, syndromal T lymphopenia, and these patients might just need follow-up at the KIT center where there's experience. The same is true for idiopathic T lymphopenia. There should as well be follow-up at an experienced center. In the case of prematurity, we recommend control starting from the age of 32 gestational weeks until the age of 14 weeks of gestation every 14 days. I have to admit that this can be complicated, and sometimes it might be necessary to go for immunophenotyping earlier. And this is, again, why we have established this hotline, and this has proven very instrumental. In the case of secondary lymphopenia, of course, the treatment should address causal disease, such as chylothorax or intestinal loss because of lymphangiectasia. It is important in parallel to the medical care, to the clinical care, to generate solid data to improve the screening process over time. And this is why we have established a national SCID registry. Of course, the patients still will be registered in the SCID registry, and the data, as I showed you earlier, will be transferred to our National Society of Newborn Screening. So you see different registration hierarchies, but I think this is the most important one up there. initially, Michael mentioned that I was involved in this process for 8 years, and yes, it's true. It took 8 years, and there's reasoning for this, because at least in Germany, there's a strong feeling by the authorities that a population-based genetic approach should carefully be counterbalanced in terms of risk and benefit. So the entire process started in 2012, where patient organizations and medical societies such as the RP approached the National Association of Statutory Health Insurance Funds for support. 1 year later, the German-speaking Pediatric Immunological Working Party, RPE, published the first screening algorithm. This has been slightly modified because initially we suggested a national drug screening combined with a crack pilot screening. Again, 1 year later, the authorities found a potential benefit for a crack screening and submitted a petition to the Federal Joint Committee, which is the decision-making organ in the German health system, for formal evaluation. Formal evaluation started in February 2015 until November 2016. And principally, there has been a systematic evaluation by this institute, which is the Institute for Information and Quality in Health Systems. They set out for literature review. They had hearings of experts, patient organizations, and so on. And finally, in the end of 2016, the authorities found a potential benefit of drug screening only, but insufficient data to go for a crack screening. So half a year later, the Joint Committee published a project draft to include SCID as a new target disease to German newborn screening. And this was sent out for a final statement hearing to all German medical societies. In November 2018, the Federal Joint Committee recommended addition of drug screening to routine newborn screening, and this had to be published in the Bundesanzeiger. This is where every novel law will be published, and this had the consequence that 6 months after the publication, newborn screening had to be in place. So once we were aware of this situation, we started developing our questionnaires for the centers that applied, and then we had a political process together with additional lean societies, and finally set the stage for the referral centers for SCID evaluation and treatment. And as you're all aware of, we now have we have 1 year now of newborn screening in Germany. However, and this might be the most important slide for all of you, at present we only have data covering the first 6 months of our newborn screening efforts in Germany. So what did we find? You can see here that we identified 21 truly positive children by newborn screening, and we found 9 cases of SCID. We found 4 cases of leaky SCID, Omen syndrome, and we found quite a high number of 8 syndromal combined immunodeficiency cases. Looking at the SCID patients, we see RAG1, JAK3, CORO1A, PCL11B, ADA, Artemis, common gamma chain, and 1 unclear case. Looking at the Omen syndromes patients, of course, we find RAG, hypomorphic, common gamma chain, Artemis deficiency, and focusing on the syndromal kids, it's quite heterogeneous again. So there's 1 case of cartilage hair hypoplasia, POX1 deficiency, which is a very complex disorder, DGeorge syndrome, Charge association, and trisomy 21. So, and I have to highlight Carsten Speckmann on behalf of the RP Newborn Screening Working Group, who has done a tremendous job in getting this data together. The incidence of SCID and leaky SCID in Germany at present is 1 to 25,000, and the incidence of SCID, leaky SCID, and syndromic KID is 1 to 15,000, and this is far beyond the expectations we made before we started screening based on the clinically diagnosed cases. So I would like to sum up for you that severe combined immunodeficiency is a developmental and or functional disorder of especially T cells, but as well B and or NK cells. It leads to a severe immunodeficiency and a severe immune dysregulation. It has a 100% lethality without treatment, but it can be cured, especially with allogeneic stem cell transplantation. The outcome of stem cell transplantation critically depends on an early diagnosis of asymptomatic patients, and drugs have been proven as an invariant and non-coding episomal biomarker for naive T cells. Germany started drug newborn screening in August 2019, and once the screening is positive, of course, the diagnosis is preliminary and has to be confirmed by flow cytometry and genetics. We have established a network of KIT hospitals and KIT centers, which will go for level 1 and level 2 diagnostics. And every SCID patient, of course, needs individualized immunology and genetics to set the stage for a proper stem cell or gene therapy treatment. Every screened patient needs a high-quality prospective documentation to improve the screening process as such and hopefully set the stage for screening for additional immunodeficiencies. And most importantly, SCID screening has substantially increased the diagnostic yield in Germany. However, long-term outcome data is not yet available. I would like to thank you for your attention. I would like to thank my colleagues from the working group for newborn screening of the RP, Michael Albert, Manfred Hönig, Sushal Ghosh, Katharina Schütz, and Carsten Speckmann. I would like to highlight ERN-RITA and ESID, of course. And I would like to conclude my talk with the following image. A negative newborn screening result is not excluding SCID or even PIT. Finally, I would like to draw your attention on the next ERN-RITA webinar that will be on hemophagocytic lymphohistiocytosis and macrophage activation syndrome on November 13th. And there will be more email communication on this. So thank you very much.
Thank you, Fabian, for this very comprehensive presentation on SCID and how it can be treated or detected by newborn screening. We have a number of questions from the audience already, and I encourage you to submit more via the questions field in your webinar system. I would like to start with a question that you have already answered very briefly, but I think it's very important because it's a very practical question. It's about the preterm babies. So the second card that you recommend, or we as in our algorithm recommend to be retested, would that be at normal term, or would that be immediately, or would there be a certain time frame within that second card has to be submitted?
Yeah, that's a very good question. It's a very important question, and it's a mind-breaking question because it's very difficult to really address this problem in the best sense for the patients. Because prematurity, of course, can be associated with lymphopenia, but prematurity can as well be associated with SCID. And a lot of these premature babies, they are very sick because of prematurity and or SCID, and might be lymphopenic for that reason as well. So it is very difficult to really get hands-on on these patients. And what we do at the present is that we recommend rescreening every 2 weeks in a healthy child. When the child otherwise is doing well, we would go for retesting every 2 weeks until the age of maturity or the drugs have normalized. When the child is sick, this will be always an individual decision. And this is why we have established our hotline. And this is why we can as well discuss these patients in between the kids centers. And whenever there's any doubt, one would feel safe to go for immune phenotyping in these children. And maybe in the future, there will be better ways to screen for our target diseases by, let's say, exome or genome sequencing upfront, which would maybe give more reliable data, but this has to be determined over time.
Yes, thank you very much. We're having a number of very interesting questions coming in. The first one refers to the incidence of a SCID now identified in Germany, and the question is it possible that the USA have missed cases as there are more cases identified in Germany?
Yeah, it is possible. At present, we only have data for 6 months. So the incidence numbers will somehow be different in 6 years, I suppose. Nevertheless, there's a dramatic difference between Germany and the US, and I would not expect to have dramatic changes over time in these numbers. So the question would be, why is it that the differences are that important? Of course, there could be consanguinity levels which might be different in the US and Germany. However, neither the US nor Germany are countries with strong consanguinity rates. And therefore, another thing that I could imagine would be that in at least in Germany, we have a nationwide documentation of residency. So everyone who's living in Germany is registered. So there won't be people missed or lost to follow up, because we know the people we have and where they are. And this might be a difference to the US, but this is pure speculation. And maybe Michael, you would like to comment on that as well, because you have a strong experience with the US system because you've done your postdoc there, right?
Yeah, correct, but not in newborn screening. True, this may be one reason, and also we may see numbers going down once we have data, as you already mentioned, for a longer time period. We have actually a couple of questions from people who ask for the false positive rates we observed in 6 months, and I wonder whether you can provide us with these numbers.
I cannot provide you with the data on false positive rates at present because we are still in the process of having them. But what I can tell you is that we have clusters of false positive findings. And this is true because of incorrect pre-analytics, for example. So when the dried blood spot is done via capillary aspiration of blood, and the capillary is containing EDTA, this can interfere with the PCR reaction. So the pre-analytics that in some place or another might be incomplete at present leads to the cluster of false positivity. And however, this can be addressed by education of the particular sites. And there's still an issue with different screening labs having different approaches to do the track screening, because we see that the cutoffs are variable and that some labs somehow have over reports having false positives, but other labs might have false negatives as well. You have to understand that Germany is a federal country, so we have 16 federal states and I think more than 10 screening labs, and this is why it is so important to have the data in a high quality, to do an analysis in some months to go to see how the different labs and the different tests perform. But it's too early to really give you absolute numbers.
Thank you very much. You're probably not, but are you aware of any false negative children? So children with SCID who were not detected by this approach? And could you, even if you don't have those numbers, can you speculate in what could happen? So a false negative result occurs?
I am aware of one false negative case. This has been an ADA SCID. And we have really digged into the reason for this child being false negative in the beginning. And when retesting the initial card, it was true positive testing. So there has been some problem, but we do not know at present why this happened.
Okay.
But it's very rare. And given the overall high incidence of identified cases, we are quite confident that this is not the major problem.
Yeah, thank you. Two questions referring to the technical method being used for track detection. Is that uniform across Germany, or are we using one or two specific products? And are there, second follow-up question, is there one cutoff level for tracks for all the labs?
It's heterogeneous. Some labs use commercially available kits. Other labs, they have developed their own platform. So it's heterogeneous. And I would say there are more than 5 to 6 different testing strategies at present, which on the one side is complicating things. On the other hand side is a strong advantage, because now we have competition as well. And with the future to come, we will be able to compare these tests, and we will see which one is performing best.
Do you know, do you have a figure of the actual cost per test that is calculated for the health insurance system in Germany?
I don't have the figure of that. And at present, it is the starting point of the screening program. So the costs are higher, because it's not only the testing kits or the chemical compounds, but as well the PCR cyclers that have to be bought and installed, and they have to be made operational. But the costs will go down during the months to come, the years to come, and then I think we will have steady state costs. But it's for all, this is all very interesting questions, but we don't have the numbers at present.
Yeah, and the interesting questions keep on coming. So very important questions. How many referrals for flow cytometry were there all overall? Do you have those numbers?
We don't have the numbers yet.
Okay. Another more clinically applicable question is the care for those babies identified with a positive screening result and who are confirmed to have SCID. Are these babies awaiting transplant at home, or are they directly admitted to the hospital for the transplant? And do we have data on pre-transplant infections in these babies from Germany as of yet? This is a highly relevant question.
This is a highly relevant question given the data from the US colleagues. At present, we don't have official recommendations which would be applicable for all the kid centers. And at present, we leave it to the kid centers to decide on how to take care for the children pre-transplant, because there's a lot of soft factors like the compliance of the family, the housing situation of the family, the size of the family with siblings or not, the profession of the family. Can people work from home, or do they have to work as a bus driver? So there's a lot of soft factors which will finally influence the decision how to overcome the pre-transplant period. As far as I know from the colleagues that already have transplanted babies by SCID screening, the data is very encouraging, and we did not lose one of the children that we have identified via screening. But it's very early at present to really give reliable data on that.
Yeah, and I can only stress this, as fortunately we have a nationwide register for SCID transplant, and we're very eager to see the first results once we have about 2 years of screening covered. We have another very interesting question coming in from a colleague from Mallorca, who is asking what's the latency between the positive screening test and the level 1 or level 2 diagnostic, and how is that for the urgent positives? I think that's a very practical question as well.
I mean, actually, I would like to be in Mallorca right now as well, but okay. The latency is quite short, and we have decided, so once the screening is positive in the lab, the sender will be contacted, and normally it only takes 1 to 2 days to really get the information to the patients. So it's quite fast. However, we have decided not to contact the patients, for example, at Friday afternoon, because then the family would be terrified, but the routine diagnostics would only be available on Monday. So let's say from Monday up to Thursday, it's quite fast, 1 to 2 days. And when there's a weekend or holiday, we will somehow retain the information, because there would not be immediate consequences for the children, and contact the families once the working life has started again.
All right. Thank you very much. I think it's now 3 p.m., so we should slowly come to a close. Thank you very much for this comprehensive talk. Thank you to the audience for listening and also and watching, and for the very excellent questions we received. And with this, I would like to again remind you of the next ERN-RITA webinar, which will be on November 13th. And we hope to have more PID-themed webinars at a higher frequency in collaboration with ESCID in the very near future. And should you have any wishes or suggestions for talks we should be having in this series, please feel free to email either me or the ERN-RITA general email. Thank you very much, Fabian, and I wish everybody a healthy and contact-less weekend in these difficult times. Thank you very much.